Lewis's Medical Surgical Nursing, 11th edition, Chapter 62, Musculoskeletal Trauma and Orthopedic Surgery. The most common cause of musculoskeletal injury is a traumatic event resulting in fracture, dislocation, subluxation, and/or soft tissue injury. Most of these injuries are not fatal. However, the cost in terms of pain, disability, medical expense, and lost wages is enormous. Accidents are one of the top 3 causes of death for persons ages 1 to 64 years. Nurses play a key role in teaching the public about basic principles of safety and accident prevention. This chapter discusses musculoskeletal problems resulting from trauma and common orthopedic surgical procedures. Following trauma or surgery, the injured area is often immobilized while healing occurs. The nurse's role in preventing complications, e.g., pressure injuries, constipation, infection, VTE, and promoting functional ability in patients with fractures and orthopedic surgery is emphasized. Health promotion. Teach people in the community to take proper safety precautions to prevent injuries while at home or work, driving, or taking part in sports. The morbidity associated with accidents can be significantly reduced if people are aware of environmental hazards, use proper safety equipment, and apply safety and traffic rules. In the work setting, teach employees and employers about using proper safety equipment and avoiding hazardous working situations. Encourage people, especially older adults, to take part in moderate exercise to help maintain muscle strength and balance. Ways to prevent common musculoskeletal problems in the older adult are listed, Table 62.1. To reduce risk for falls, urge them to wear non-skid, hard-soled footwear and assess their living environment for safety risks, e.g., remove throw rugs, ensure adequate lighting, maintain clear paths to the bedroom for nighttime use. Stress the importance of adequate calcium and vitamin D intake for bone health. Soft tissue injuries. Soft tissue injuries include sprains, strains, dislocations, and subluxations. They usually result from trauma. As more people have become involved in fitness programs or sports, the incidence of soft tissue injuries has increased. Common sports-related injuries are described in Table 62.2. Sports injuries that often result in a visit to the emergency department for younger patients include sprains and strains, growth plate injuries, and repetitive motion injuries. Sprains and strains. Sprains and strains often result from abnormal stretching or twisting forces during vigorous activities. These injuries tend to occur around joints and in the spinal musculature. A sprain is an injury to the ligaments surrounding a joint. Sprains are usually caused by a wrenching or twisting motion. Most occur in the ankle, wrist, and knee joints. A sprain is classified according to the degree of ligament damage. A first-degree mild sprain involves tears in only a few fibers with mild tenderness and minimal swelling. A second-degree moderate sprain results in partial disruption of the involved tissue with more swelling and tenderness. A third-degree severe sprain is a complete tear of the ligament with moderate to severe swelling. A strain is an excessive stretching of a muscle and its fascial sheath, often involving the tendon. Most strains occur in the large muscle groups, including the lower back, calf, and hamstrings. Strains are classified as first-degree, mild or slightly pulled muscle, second-degree, moderate or moderately torn muscle, and third-degree, severely torn or ruptured muscle. A defect in the muscle may be apparent or palpated through the skin if the muscle is torn. Because areas around joints are rich in nerve endings, the injury can be very painful. Manifestations of sprains and strains are similar. They include pain, edema, decreased function, and bruising. Continued use of the joint tendon or ligament makes pain worse. Edema develops in the injured area because of the local inflammatory response. Mild sprains and strains are usually self-limiting. Full function generally returns within 3 to 6 weeks. X-rays of the affected part may be taken to rule out a fracture. A severe sprain can cause an avulsion fracture in which the ligament pulls loose a fragment of bone. The joint structure may become unstable, causing subluxation or dislocation. At the time of injury, hemarthrosis, bleeding into a joint space or cavity, or disruption of the synovial lining may occur. Severe strains may need surgical repair of the muscle tendon or surrounding fascia. Nursing management, sprains and strains. Nursing implementation, health promotion. Warming up muscles before exercising and vigorous activity, followed by stretching, may significantly reduce the risk of sprains and strains. Strength, balance, and endurance exercises are important. Strengthening exercises that involve working against resistance build muscle strength and bone density. Balance exercises, which may overlap with some strengthening exercises, help prevent falls. Endurance exercises should start at a low level of effort, progress gradually to a moderate level. Acute care. If an injury occurs, immediate care focuses on 1. Stopping the activity and limiting movement to the injured part, 2. Applying ice packs to the injured area, 3. Compressing the involved area, 4. Elevating the extremity, and 5. Providing analgesia as needed. Most sprains and strains are treated in the outpatient setting. RICE, rest ice compression elevation, may decrease local inflammation and pain for most musculoskeletal injuries. Movement should be restricted and the extremity rested as soon as pain is felt. Unless the injury is severe, prolonged rest is usually not needed. There are several forms of cold therapy, cryotherapy, we can use. Cold causes vasoconstriction in the soft tissue and reduces the transmission and perception of nerve pain impulses. These changes also reduce muscle spasms, inflammation, and edema. Cold is most useful when applied immediately after an injury has occurred and used for 24 to 48 hours. Apply ice no more than 20 to 30 minutes at a time. Do not apply ice directly to the skin. Compression helps decrease edema and pain. We often use an elastic compression bandage. It can be wrapped around the injured part. To prevent edema and encourage fluid return, wrap the bandage starting distally at the point farthest from the trunk of the body and progress proximally toward the trunk of the body. The bandage is too tight if there is numbness or tingling below the area of compression or pain, or more swelling occurs beyond the edge of the bandage. Leave the bandage in place for 30 minutes, then remove it for 15 minutes. Use of an elastic wrap may provide extra support during training, athletic, and work activities. Elevate the injured part above heart level, even during sleep, for 28 to 48 hours to help mobilize excess fluid from the area and prevent further edema. Mild analgesics and NSAIDs may be used to manage patient discomfort. After the acute phase, usually 24 to 48 hours, apply warm, moist heat to the affected part to reduce swelling and provide comfort. Heat applications should not exceed 20 to 30 minutes, allowing a cool down time between applications. Encourage the patient to use the limb if the joint is protected by a cast, brace, splint, or taping. Joint movement maintains nutrition to the cartilage. Muscle contraction improves circulation and helps resolve bruising and swelling. Movement also helps to prevent contracture, stiffening of tendons and ligaments. Emphasize the importance of strengthening and conditioning exercises to prevent re-injury. The physical therapist may help with pain relief by using ultrasound or other interventions. The therapist may also teach the patient exercises to improve flexibility and strength. Dislocation and subluxation. Dislocation is the complete displacement or separation of the articular surfaces of the joint. Subluxation is a partial or incomplete displacement of the joint surface. Symptoms of subluxation are similar to those of a dislocation, but are less severe. Multiple structures contribute to the stability of a joint. Injury to or excessive laxity of ligaments is a major factor in dislocations or subluxations. Weak or atrophied muscles can cause chronic joint instability. Fibrocartilage structures, such as the labrum around hip and shoulder sockets and the meniscus at the knee, play an important role in joint stability. Even small tears to these structures can result in recurrent chronic dislocations or subluxations. Dislocations typically result from forces on the joint that disrupt the surrounding soft tissue support structures. The joints most often dislocated in the upper extremity include the thumb, elbow, and shoulder. The shoulder most often dislocates anteriorly. Posterior shoulder dislocations are rare. They typically only happen after electrocution or seizure. In the lower extremity, the hip is vulnerable to dislocation from severe trauma, often associated with motor vehicle crashes. The kneecap, patella, may dislocate because of a sharp, direct blow or after a sudden twisting inward motion while the planted foot is pointed outward. The most obvious sign of a dislocation is deformity. For example, if the hip dislocates in a posterior or backward direction, the affected limb may be shorter and internally rotated. Other manifestations include local pain, tenderness, loss of function of the injured part, and swelling of soft tissues near the joint. Major complications of a dislocated joint are open joint injuries, intra-articular fractures within the joint, avascular necrosis, bone cell death from blood supply, and damage to adjacent nerves and blood vessels. X-rays can determine the extent of displacement. The joint may be aspirated to assess for hemarthrosis or fat cells. Fat cells in the aspirate indicate a probable intra-articular fracture. Interprofessional and nursing care. A dislocation requires prompt attention. It is often considered an orthopedic emergency because it may be associated with significant vascular injury. The longer the joint is dislocated, the greater the risk for avascular necrosis. The femoral head of the hip joint is especially susceptible to avascular necrosis. Compartment syndrome may occur after dislocation due to vascular injury and resulting ischemia. Neurovascular assessment is critical. The first goal of management of a dislocation is to realign the dislocated part of the joint to its original anatomic position. Closed reduction, no incision, may be done under local or general anesthesia or IV moderate to deep sedation. Anesthesia is often needed to relax the muscle so that the bones can be manipulated. Sometimes open reduction, joint visualized through surgical incision, may be needed. After reduction, the extremity is immobilized by a brace, splint, or sling, or by taping to allow torn ligaments and surrounding tissue to heal. Nursing management is directed toward pain management and support and protection of the injured joint. After the joint has been reduced and immobilized, motion is usually restricted. A carefully monitored rehabilitation program can prevent further instability and joint dysfunction. Gentle range of motion ROM exercises may be done if the joint is stable and well supported. An exercise program slowly restores the joint to its original ROM without causing another dislocation. The patient should gradually return to normal activities. A patient who has dislocated a joint may be at greater risk for repeated dislocations because of damage or laxity to the previously mentioned structures. Activity restrictions may be imposed on the affected joint to decrease the risk for repeated dislocations. Repetitive strain injury. RSI and cumulative trauma disorder are terms used to describe injuries resulting from prolonged force or repetitive movements and awkward postures. RSI is also called repetitive trauma disorder, non-traumatic musculoskeletal injury, overuse syndrome, sports medicine, regional musculoskeletal disorder, and work-related musculoskeletal disorder. Repeated movements strain the tendons, ligaments, and muscles, causing tiny tears that become inflamed. The exact cause of these disorders is unknown. No specific diagnostic tests exist. Diagnosis is often difficult. Persons at risk for RSI include musicians, dancers, butchers, grocery clerks, vibratory tool workers, and those who frequently use a computer, mouse, and keyboard. Competitive athletes and poorly trained athletes may develop RSI. Swimming, overhead throwing, e.g. baseball, weightlifting, gymnastics, tennis, skiing, and kicking sports, e.g. soccer, require repetitive motion. Overtraining compounds the effects of RSI. Other factors related to RSI include poor posture and positioning, poor workplace ergonomics, badly designed workplace equipment, e.g. computer keyboard, repetitive lifting of heavy objects without sufficient muscle rest. Inflammation, swelling, and pain in the muscles, tendons, and nerves of the neck, spine, shoulder, forearm, and hand may result. Symptoms of RSI include pain, weakness, numbness, or impaired motor function. RSI can be prevented through education and ergonomics, science that promotes efficiency and safety in the interaction of humans in their work environment. For example, ergonomic considerations for those who work at a desk and use a computer include keeping the hips and knees flexed to 90 degrees with the feet flat, keeping the wrist straight to type, having the top of the computer monitor even with the forehead, taking at least hourly stretch breaks. Once RSI is diagnosed, treatment consists of 1. Identifying the precipitating activity, 2. Modifying equipment and or activity, 3. Pain management, including heat or cold therapy and NSAIDs, 4. Rest, 5. Physical therapy, PT, for strengthening and conditioning exercises, and 6. Lifestyle changes. Carpal tunnel syndrome. CTS is caused by compression of the median nerve, which enters the hand at the wrist through the narrow carpal tunnel. Carpal tunnel is formed by ligaments and bones. CTS is the most common compression neuropathy in the upper extremity. It is associated with hobbies or work that require continuous wrist movements, e.g. musicians, carpenters, computer operators. CTS is often caused by pressure from trauma or edema due to inflammation of a tendon, tenosynovitis, cancer, rheumatoid arthritis, RA, or soft tissue masses such as ganglia. Hormones may be involved because CTS often occurs during the premenstrual period, pregnancy, and menopause. Persons with diabetes, peripheral vascular disease, and RA have a higher incidence of CTS because of swelling that changes blood flow to the nerve and narrows the carpal tunnel. Women are more likely than men to develop CTS, possibly because of a smaller carpal tunnel. Manifestations of CTS are impaired sensation, pain, numbness, or weakness in the distribution of the median nerve. Numbness and tingling may awaken the patient at night. Shaking the hands often relieves these symptoms. Clumsiness in performing fine hand movements is common. The patient may have a positive Tinel's sign and Phelan's sign. Tinel's sign can be elicited by tapping over the median nerve as it passes through the carpal tunnel in the wrist. A positive response is a sensation of tingling in the distribution of the median nerve over the hand. Phelan's sign can be elicited by allowing the wrist to fall freely into maximum flexion and maintaining the position for longer than 60 seconds. Positive response is a sensation of tingling in the distribution of the median nerve over the hand. In late stages, atrophy of the muscles around the base of the thumb result in recurrent pain and eventual dysfunction of the hand. To prevent CTS, teach employees and employers to identify risk factors. Adaptive devices such as wrist splints may be worn to hold the wrist in a slight extension and relieve pressure on the median nerve. Special keyboard pads and computer mice that prevent repetitive pressures on the median nerve are available for computer users. Other ergonomic changes include workstation modifications, change in body positions, and frequent breaks from work-related activities. Care of the patient with CTS is directed toward relieving the underlying cause of the nerve compression. Early symptoms of CTS can usually be relieved by stopping the aggravating movement and by resting the hand and wrist by immobilization in a hand splint. Splints worn at night help keep the wrist in a neutral position and may reduce night pain and numbness. PT with hand and wrist exercises may lessen symptom severity. A corticosteroid injection directly into the carpal tunnel may give short-term relief. The patient may need to consider a change in occupation because of discomfort and sensory changes. Carpal tunnel release is generally done if symptoms last more than 6 months or if there is significant impairment to conduction on electromyography, EMG. Surgery involves severing the band of tissue around the wrist to reduce pressure on the median nerve. Surgery is done in the outpatient setting using local anesthesia. The types of carpal tunnel release surgery include open release and endoscopic surgery. In open release surgery, an incision is made in the wrist, and then the carpal ligament is cut to enlarge the carpal tunnel. Endoscopic carpal tunnel release is performed through one or more small puncture incisions in the wrist and palm. The camera is attached to a tube, and the carpal ligament is cut. The endoscopic approach may allow a faster recovery and cause less discomfort than traditional open release surgery. Although symptoms may be relieved right after surgery, full recovery may take months. After surgery, assess the hand's neurovascular status. Teach the patient about wound care and assessments to perform at home. Rotator cuff injury. The rotator cuff is made up of 4 muscles in the shoulder: the supraspinatus, infraspinatus, teres minor, and subscapularis muscles. These muscles stabilize the humeral head in the glenoid fossa while assisting with ROM of the shoulder joint and rotation of the humerus. A tear in the rotator cuff may occur as a gradual, degenerative process due to aging, repetitive stress, especially overhead arm motions, or injury to the shoulder. In sports, repetitive overhand motions, such as in swimming, weightlifting, and swinging a racket, tennis, racquetball, often cause injury. The rotator cuff can tear because of sudden adduction forces applied to the cuff while the arm is held in abduction. Other causes include 1. Falling onto an outstretched arm and hand, 2. A blow to the upper arm, 3. Heavy lifting, or 4. Repetitive work motions. Manifestations include shoulder weakness, pain, and decreased ROM. The patient usually has severe pain when the arm is abducted between 60 and 120 degrees, the painful arc. A positive drop arm test is a sign of rotator cuff injury. In this test, the arm is abducted 90 degrees and the patient is asked to slowly lower the arm to the side. If the arm falls suddenly, rotator cuff injury is suspected. An X-ray alone is not helpful in the diagnosis. A tear can usually be confirmed by MRI. The patient with a partial tear or cuff inflammation may be treated conservatively with rest, ice, and heat. NSAIDs, corticosteroid injections into the subacromial space, ultrasound, and PT. If the patient does not respond to conservative treatment or if a complete tear is present, surgical repair may be needed. Most surgical repairs are done as outpatient procedures through an arthroscope. If the tear is extensive, part of the acromion may be surgically removed, acromioplasty, to relieve compression of the rotator cuff during movement. A shoulder immobilizer with an abduction pillow is typically used for 6 weeks after surgery to limit shoulder movement. However, the shoulder should not be immobilized for too long because frozen shoulder, arthrofibrosis, may occur. Pendulum exercises and other passive exercises typically begin the first post-operative day. Active PT starts after 6 weeks of immobilization. Weight restrictions for lifting are usually given. Full recovery may take 6 to 12 months. Meniscus injury. The menisci are crescent-shaped pieces of fibrocartilage in the knee. Menisci are also found in other joints, including the AC, sternoclavicular, and TMJ. Meniscus injuries are associated with ligament sprains common among athletes in sports such as basketball, football, soccer, and hockey. These activities produce rotational stress when the knee is in varying degrees of flexion and the foot is planted or fixed. A blow to the knee can cause shearing of the meniscus between the femoral condyles and tibial plateau, causing a torn meniscus. Older adults and people who have jobs that require squatting or kneeling are at risk for degenerative tears. Meniscus injuries alone do not usually cause significant edema because most cartilage is avascular. However, an acutely torn meniscus may present with localized tenderness, pain, and effusion. Pain occurs with flexion, internal rotation, and then extension of the knee, McMurray's test. The patient may feel that the knee is unstable and often reports that the knee clicks, pops, locks, or gives way. Quadriceps atrophy is usually present if the injury has been present for some time. Traumatic arthritis may occur from repeated meniscus injury and chronic inflammation. MRI can confirm the diagnosis before arthroscopy. The patient's age, occupation, sport activities, degree of knee pain, and dysfunction may affect the decision whether to have surgery. Interprofessional and nursing care. Most meniscus injuries are treated in an outpatient setting. The acutely injured knee should be examined within 24 hours of injury. Initial care involves ice application, immobilization, and use of crutches with weight bearing as tolerated. Using a knee brace or immobilizer during the first few days after the injury protects the knee and offers some pain relief. After acute pain has decreased, PT can help the patient regain knee flexion and muscle strength to aid in returning to full function. Teach athletes to do warm-up exercises to reduce the risk for sports-related injuries. In older adults with degenerative meniscus tears, progressive exercise therapy may improve neuromuscular function and muscle strength. Surgical repair or excision as part of the meniscus, meniscectomy, may be needed. Meniscal surgery is done by arthroscopy. Pain relief may include NSAIDs or other analgesics. Rehabilitation starts soon after surgery, including quadriceps and hamstring strengthening exercises and ROM. When the patient's strength is back to its pre-injury level, normal activities may be resumed. Anterior cruciate ligament injury. Knee injuries account for more than 50% of all sports injuries. The most commonly injured knee ligament is the ACL. ACL injuries are usually non-contact injuries that occur when the athlete pivots, lands from a jump, or stops abruptly when running. Patients often report coming down on the knee, twisting, and hearing a pop, followed by acute knee pain and swelling. The knee may feel unstable. Athletes usually cannot continue playing. Injury to the ACL can result in a partial tear, a complete tear, or an avulsion, tearing away from the bones that form the knee. A positive Lachman's test suggests an ACL tear. This test is done by flexing the knee 15 to 30 degrees and pulling the tibia forward while the femur is stabilized. The test is considered positive for an ACL tear if forward motion of the tibia occurs with the feeling of a soft or indistinct endpoint. MRI is often used to diagnose an ACL tear and coexisting conditions, including a fracture, meniscus tearing, and collateral ligament injuries. Interprofessional and nursing care. Prevention programs can significantly reduce ACL injuries in athletes. Conservative treatment for an intact ACL injury includes rest, ice, NSAIDs, elevation, and ambulation is tolerated with crutches. If present, a tight, painful effusion may be aspirated. A knee immobilizer or hinged knee brace may provide support. PT often helps the patient maintain knee joint motion and muscle tone. Reconstructive surgery is usually recommended for physically active patients who have sustained severe injury to the ACL and meniscus. In reconstruction, the torn ACL tissue is removed and replaced with graft tissue. ROM is encouraged soon after surgery. The knee is placed in a brace or immobilizer. Rehabilitation with PT is critical, with progressive weight bearing determined by the degree of surgical repair. A safe return to the patient's prior level of physical functioning may take 6 to 8 months. Bursitis. Bursae are closed sacs that are lined with synovial membrane and contain a small amount of synovial fluid. They are found at sites of friction, such as between tendons and bones and near the joints. Bursitis, inflammation of the bursa, results from repeated or excessive trauma or friction. Gout, RA, or infection. Symptoms of bursitis include warmth, pain, swelling, and limited ROM in the affected part. Common sites are the hands, elbows, shoulders, knees, and great trochanters of the hip. Improper body mechanics, repetitive kneeling, carpet layers, coal miners, and gardeners, jogging in worn-out shoes, and prolonged sitting with crossed legs are common precipitating activities. Try to determine and correct the cause of bursitis. Rest is often the only treatment needed. The affected part may be immobilized in a compression dressing or splint. Ice and NSAIDs can reduce pain and inflammation. Aspiration of the bursal fluid and intra-articular corticosteroid injection may be needed. If the bursal wall has become thickened and continues to interfere with normal joint function, surgical excision, bursectomy, may be done. Septic bursae may be treated with oral antibiotics, but usually need surgical incision and drainage. Fractures. Classification. A fracture is a disruption or break in the continuity of bone. Although traumatic injuries cause most fractures, some fractures are due to disease process, such as cancer or osteoporosis, pathologic fracture. We classify fractures in several ways. Fractures are described as open or closed based on communication with the external environment. In an open fracture, skin is broken and bone exposed, causing soft tissue injury. In a closed fracture, the skin is intact over the site. We also describe fractures as complete or incomplete. Fracture is complete if the break goes completely through the bone. An incomplete fracture occurs partly across a bone shaft, but the bone is still intact. An incomplete fracture is often the result of bending or crushing forces applied to a bone. Fractures are identified according to the direction of the fracture line. Types include linear, oblique, transverse, longitudinal, and spiral. Finally, fractures can be classified as displaced or non-displaced. In a displaced fracture, the two ends of the broken bone are separated from each other and out of their normal positions. Displaced fractures are often comminuted, more than two fragments, or oblique. In a non-displaced fracture, the bone fragments stay in alignment. Non-displaced fractures are usually transverse, spiral, or green stick. Manifestations. Manifestations include immediate localized pain, decreased function, and inability to bear weight or use the affected part. The patient guards and protects the extremity against movement. Obvious bone deformity may be present. Fracture healing. Knowledge of the stages of fracture healing is needed to provide appropriate interventions. Bone goes through a complex, multi-stage healing process, union, that occurs in 6 stages. 1. Fracture hematoma. When a fracture occurs, bleeding creates a hematoma that surrounds the ends of the bone fragments. The hematoma is composed of extravasated blood that changes from a liquid to a semisolid clot in the first 72 hours after injury. 2. Granulation tissue. During this stage, active phagocytosis absorbs the products of local necrosis. The hematoma converts to granulation tissue. Granulation tissue, consisting of new blood vessels, fibroblasts, and osteoblasts, forms the basis for new bone substance, osteoid, during days 3 to 14 after injury. Callus formation. As minerals, calcium, phosphorus, and magnesium, and new bone matrix are deposited into the osteoid, an unorganized network of bone is formed and woven about the fracture parts. Callus is primarily composed of cartilage, osteoblasts, calcium, and phosphorus. It usually appears by the end of the second week after injury. An X-ray can show evidence of callus formation. 4. Ossification. Ossification of the callus occurs from 3 weeks to 6 months after the fracture and continues until the fracture has healed. Callus ossification is sufficient to prevent movement at the fracture site when the bones are gently stressed. However, the fracture is still evident on X-ray. During this stage of clinical union, patient may be allowed limited mobility or the cast may be removed. Consolidation. As callus continues to develop, the distance between bone fragments decreases and eventually closes. Ossification continues and can be equated with radiologic union, which occurs when an X-ray shows complete bony union. This phase can occur up to 1 year after injury. 6. Remodeling. Excess bone tissue is resorbed in the last stage of bone healing, and union is complete. Gradual return of the injured bone to its pre-injury structural strength and shape occurs. Bone remodels in response to physical loading stress, Wolff's Law. Initially, stress is provided through exercise. Weight bearing is gradually introduced. New bone is deposited in sites subjected to stress and resorbed at areas of little stress. Many factors influence the time needed for complete fracture healing. They include displacement and site of the fracture, blood supply, other local tissue injury, immobilization, and use of internal fixation devices, e.g. screws, pins. Ossification may be slowed or even stopped by inadequate immobilization, excessive movement of fracture fragments, infection, poor nutrition, and systemic disease, e.g. diabetes. Healing time for fractures increases with age. For example, an uncomplicated mid-shaft femur fracture heals in 3 weeks in an infant and in 20 weeks in an adult. Smoking increases fracture healing time. Fracture healing may not occur in the expected time, delayed union, or may not occur at all, non-union. Interprofessional care. The overall goals of fracture treatment are 1. Anatomic realignment of bone fragments through reduction, 2. Immobilization to maintain realignment, and 3. Restoration of normal or near normal function of the injured part. Fracture reduction. Closed reduction. Closed reduction is the non-surgical, manual realignment of bone fragments to their anatomic position. Traction and countertraction are manually applied to the bone fragments to restore position, length, and alignment. Closed reduction is usually done while the patient is under local or general anesthesia. Traction, casting, splints, or orthoses, braces, may be used after reduction to maintain alignment and immobilize the injured part until healing occurs. Open reduction. Open reduction is the correction of bone alignment through a surgical incision. It usually includes internal fixation of the fracture with wires, screws, pins, plates, intermedullary rods, or nails. The type and location of the fracture, patient age, and concurrent disease influence the decision to use open reduction. The main risks of open reduction are infection, complications associated with anesthesia, and effects of pre-existing medical conditions, e.g. diabetes. However, open reduction internal fixation, ORIF, facilitates early ambulation, thus decreasing the risk for complications related to prolonged immobility. Traction. Traction is the application of a pulling force to an injured or diseased body part or extremity. Traction is used to 1. Prevent or reduce pain and muscle spasm, e.g. whiplash, unrepaired hip fracture. 2. Immobilize a joint or part of the body. 3. Reduce a fracture or dislocation. And 4. Treat a pathologic joint condition, e.g. tumor, infection. Traction is also used to 1. Provide immobilization to prevent soft tissue damage. 2. Promote active and passive exercise. 3. Expanded joint space during arthroscopic procedures. And 4. Expanded joint space before major joint reconstruction. Traction devices apply a pulling force on a fractured extremity to attain realignment, while countertraction pulls in the opposite direction. The most common types of traction are skin traction and skeletal traction. Skin traction is generally used for short-term treatment, 48 to 72 hours, until skeletal traction or surgery is possible. Tape, boots, or splints are applied directly to the skin, mainly to help decrease muscle spasms in the injured extremity. Traction weights are usually 5 to 10 pounds. Bucks traction is a type of skin traction sometimes used for the patient with a hip, knee, or femur fracture. Pelvic or cervical skin traction may require heavier weights applied intermittently. In skin traction, regular assessment of the skin is a priority because pressure points and skin breakdown may develop quickly. Assess key pressure points every 2 to 4 hours. Skeletal traction is used to align injured bones and joints or to treat joint contractures and congenital hip dysplasia. It provides a long-term pull that keeps the injured bones and joints aligned. To apply skeletal traction, the HCP inserts a pin or wire into the bone, and weights are attached to align and immobilize the injured body part. Weight for skeletal traction ranges from 5 to 45 pounds. The use of too much weight can result in delayed union or non-union. The major complications of skeletal traction are infection at the pin insertion site and the effects of prolonged immobility. A common type of skeletal traction is balanced suspension traction. Fracture alignment depends on the correct positioning and alignment of the patient while the traction forces stay constant. For extremity traction to be effective, forces also must be pulling in the opposite direction, countertraction. Countertraction is supplied by the patient's body weight or by weights pulling in the opposite direction. Elevating the end of the bed can help. Traction must be maintained continuously. Keep the weights off the floor and moving freely through the pulleys. Fracture immobilization. Fracture immobilization is achieved with casts, braces, splints, immobilizers, and external and internal fixation devices. Casts. Casts is a temporary immobilization device, often applied after a closed reduction. It allows the patient to perform many normal ADLs while providing enough immobilization to ensure stability. A cast generally immobilizes the joints above and below fracture. This restricts tendon and ligament movement, thus assisting with joint stabilization while the fracture heals. Two most common cast materials are natural, plaster of Paris, and fiberglass. We use fiberglass casts most often because they are lighter, relatively waterproof, and longer wearing than plaster of Paris. They also allow early weight bearing. Plaster of Paris is now used primarily for contact casting in the treatment of diabetic foot ulcers. To apply a cast to an extremity, first cover the affected part with stockinette that is cut longer than the extremity. Then place cotton padding over the stockinette with extra padding for bony prominences. If using plaster, immerse it in warm water and then wrap and mold it around the affected part. The number of layers of plaster bandage and technique of application determines the strength of the cast. The plaster sets within 15 minutes, so the patient may move around without difficulty. However, it is not strong enough for weight bearing until about 36 to 72 hours after application. The decision about the patient's weight bearing is made by the HCP. Casts made of fiberglass or other synthetic materials, thermoplastic resins, polyurethane, are activated by submersion in cool or tepid water. Then they are molded to fit the torso or extremity. Leave a fresh plaster cast uncovered to allow air circulation. Covering the cast allows heat to build up in the cast. This may cause a burn and delay drying. Avoid direct pressure on the cast during the drying period. Handle a cast gently with an open palm to avoid denting the cast. Once the cast is thoroughly dry, the rough edges may be pedaled to minimize skin irritation. Pedaling also prevents plaster of Paris debris from falling into the cast, causing irritation or pressure necrosis. Place several strips, pedals, of tape over the rough areas to ensure a smooth cast edge. Upper extremity injuries. An acute fracture or soft tissue injury of the upper extremity can be immobilized by using a 1. Sugar tong splint, 2. Posterior splint, 3. Short arm cast, or 4. Long arm cast. The sugar tong splint is applied for acute wrist injuries or injuries that may result in significant swelling. Splints are placed over a well-padded forearm, beginning at the phalangeal joints of the hand, extending up the dorsal aspect of the forearm, around the distal humerus, and then down the volar aspect of the forearm to the distal palmar crease. The splinting material is wrapped around with either elastic bandage or bias stockinette. The sugar tong posterior splint accommodates early swelling in the fractured extremity. The short arm cast is often used for the treatment of stable wrist or metacarpal fractures. An aluminum finger splint can be built into the short arm cast for treatment of phalangeal injuries. The short arm cast is a circular cast extending from the distal palmar crease to the proximal forearm. The cast immobilizes the wrist and allows unrestricted elbow motion. The long arm cast is often used for stable forearm or elbow fractures and unstable wrist fractures. It is similar to the short arm cast, but extends to the proximal humerus, restricting motion at the wrist and elbow. Support the extremity and reduce edema by elevating the extremity with a sling. However, when a hanging arm cast is used for a proximal humerus fracture, avoid elevation or use of a supportive sling. The hanging provides traction and maintains fracture alignment. When a sling is used, ensure the axillary area is well padded to prevent skin breakdown from direct skin-to-skin contact. Apply the sling carefully to avoid putting undue pressure on the neck. Encourage movement of the fingers, unless contraindicated, to decrease edema by enhancing the pumping action of the blood vessels. Teach the patient to actively move joints of the upper extremity, not immobilized, to prevent stiffness and contractures. Vertebral injuries. The body jacket brace is used for immobilization and support for stable spine injuries of the thoracic or lumbar spine. The brace goes around the chest and abdomen, extending from above the nipple line to the pubis. After application of the brace, assess the patient for the development of superior mesenteric artery syndrome, CAST syndrome. This condition occurs if the brace is too tight, compressing the superior mesenteric artery against the duodenum. The patient generally has abdominal pain, abdominal pressure, nausea, and vomiting. Assess the abdomen for decreased bowel sounds. There may be a window in the brace over the umbilicus. Treatment of CAST syndrome includes gastric decompression with an NG tube and suction. Assess respiratory status, bowel and bladder function, and areas of pressure over the bony prominences, especially the iliac crest. The brace may have to be adjusted or removed if any complications occur. Lower extremity injuries. Injuries to the lower extremity can be immobilized with a long leg cast, short leg cast, cylinder cast, or prefabricated splint or immobilizer. The usual indications for a long leg cast are an unstable ankle fracture, soft tissue injuries, a fractured tibia, and knee injuries. The cast usually extends from the base of the toes to the groin and gluteal crease. The short leg cast is used for stable ankle and foot injuries. A cylinder cast is used for knee injuries or fractures. It extends from the groin to the malleoli of the ankle. A Robert Jones dressing may be used temporarily to limit mobility of the joint. It is composed of soft padding materials, absorption, dressing, and cotton sheet wadding, splints, and an elastic wrap or bias cut stockinette. After application of a lower extremity cast or dressing, elevate the extremity above the heart on pillows for the first 24 hours. After that, a casted extremity should not be placed in a dependent position, as this may increase edema. After cast application, observe for signs of compartment syndrome and increased pressure, especially in the heel, anterior tibia, head of the fibula, and malleoli. Increased pressure presents as pain or a burning feeling in these areas. Prefabricated knee and ankle splints and immobilizers are used in many settings. This type of immobilization is easy to apply and remove, which allows close observation of the affected joint for swelling and skin breakdown. Depending on the injury, removal of the splint or immobilizer promotes ROM of the affected joint and faster return to function. The hip spica cast is mainly used for femur fractures in children to immobilize the affected extremity and trunk. It extends from above the nipple line to the base of the foot, single spica. It may include the opposite extremity up to an area above the knee, spica and a half, or both extremities, double spica. Assess the patient with a hip spica cast for the same problems associated with the body jacket brace. External fixation. An external fixator is composed of metal pins and wires that are inserted into the bone and attached to external rods to stabilize the fracture while it heals. It can be used to apply traction or to compress fracture fragments and immobilize reduced fragments when the use of a cast or traction is not appropriate. The external device holds fracture fragments in place similar to a surgically implanted internal device. External fixation is used mainly for complex fractures with extensive soft tissue damage, correction of congenital bony defects, non-union or malunion, and limb lengthening. External fixation is often used to try to salvage extremities that otherwise may require amputation. Because the use of an external device is a long-term process, ongoing assessment for pin loosening and infection is critical. Infection may require removal of the device. Teach the patient and caregiver about meticulous pin care. Although each HCP has a protocol for pin care cleaning, chlorhexidine is often used. Internal fixation. Internal fixation devices, pins, plates, intramedullary rods, metal, and bioabsorbable screws are surgically inserted to realign and maintain position of bony fragments. These metal devices are biologically inert and made from stainless steel, thallium, or titanium. Proper alignment and bone healing are evaluated regularly by X-rays. Electrical bone growth stimulation. Electrical bone growth stimulation can promote healing, especially with fracture, non-union, or delayed union. The mechanism of action may include 1. Increasing calcium uptake and the production of bone growth factors, 2. Increasing collagen synthesis, and 3. Promoting the growth of new blood vessels. There are non-invasive, semi-invasive, and invasive methods of electrical bone growth stimulation. Non-invasive stimulators use direct current or pulsated electromagnetic fields, PEMFs, to generate a weak electrical current. Electrodes are typically in a band applied over the patient's skin or cast and worn 10 to 12 hours each day, usually while the patient is sleeping. Semi-invasive or percutaneous bone growth stimulators use an external power supply and electrodes that are inserted through the skin and into the bone. Invasive stimulators require surgical implantation of a current generator in an IM or subcutaneous space. An electrode is implanted in the bone fragments. Drug therapy. Patients with fractures have varying degrees of pain associated with muscle spasms. Central and peripheral muscle relaxants, such as carisoprodol, soma, cyclobenzaprine, or methocarbamol, robaxin, may be given to manage pain associated with muscle spasms. Give tetanus and diphtheria toxoid or tetanus immunoglobulin to the patient with an open fracture who has not been previously immunized or whose immunization is expired. Bone-penetrating antibiotics such as cephalosporin, e.g. cefazolin, are used prophylactically before surgery. Nutritional therapy. Proper nutrition is essential to ensure optimal soft tissue and bone healing. An adequate energy source is needed to promote muscle strength and tone, build endurance, provide energy for ambulation, and gait training skills. Patients' dietary requirements must include adequate protein, e.g. 1 gram per kilogram of body weight, vitamins, especially B, C, and D, calcium, phosphorus, and magnesium, low serum protein, and vitamin C deficiencies interfere with tissue healing. Immobility and bone healing increase calcium needs. A fluid intake of 2,000 to 3,000 milliliters per day promotes optimal bladder and bowel function. Adequate fluid and a high fiber diet with fruits and vegetables prevent constipation. If immobilized in bed with skeletal traction or in a body jacket brace, patients should eat 6 small meals. This helps avoid overeating that can cause abdominal pressure and cramping. Nursing management, fractures. Nursing assessment. A brief history of the traumatic episode, mechanism of injury, and position in which the patient was found can be obtained from the patient or witness. As soon as possible, the patient should be transported to an ED, where thorough assessment can be done and treatment started. Subjective and objective data that should be obtained from a person with a fracture are outlined in table 62.8. If a fracture is suspected, the extremity is immobilized in the position which it's found. Unnecessary movement increases risk for damage to adjacent nerves and blood vessels. It may also convert a closed fracture to an open fracture. Neurovascular assessment. A thorough neurovascular assessment of the affected extremity distal to the fracture site is a primary concern. Musculoskeletal injuries may cause changes in the neurovascular status of an injured extremity. Poor positioning, physiologic responses to traumatic injury, and application of a cast or constrictive dressing can cause neurovascular damage, usually distal to the injury. Record clinical findings before fracture treatment. This way, if a problem occurs later, it will help determine if it was missed during the original examination or a result of treatment. The neurovascular assessment consists of peripheral vascular assessment, color, temperature, cap refill, peripheral pulses, edema, and peripheral neurologic assessment, sensation, motor function, pain. Throughout the neurovascular assessment, compare both extremities to obtain an accurate assessment. Assess an extremity's color, pink, pale, cyanotic, and temperature, hot, warm, cool, cold, around the injury. Pallor, or a cool to cold extremity below the injury, could indicate arterial insufficiency. A warm, cyanotic extremity could indicate poor venous return. Next, assess capillary refill. A delay in returning to its original color, greater than 3 seconds, can occur with arterial insufficiency. Compare pulses on the unaffected and injured extremities to identify differences in rate or quality. This contralateral evaluation is critical. A decreased or absent pulse distal to the injury can indicate vascular dysfunction and insufficiency. Assess peripheral edema. Pitting edema may be present with severe injury. Assess ulnar, median, and radial nerve function to evaluate sensation and motor innervation in the upper extremity. Assess motor function by asking the patient to 1. Abduct the fingers, ulnar nerve, 2. Oppose the thumb and small finger, median nerve, and 3. Flex and extend the wrist or the fingers, finicast, radial nerve. In the lower extremity, assess the patient's ability to perform dorsiflexion, peroneal nerve, and plantar flexion, tibial nerve. Evaluate sensory function of the peroneal nerve by touching the web space between the great and second toes. Stroke the plantar surface sole of the foot to assess sensory function of the tibial nerve. Patient may report paresthesia, abnormal sensation, e.g. numbness, tingling, and hypersensation or hyperesthesia. Partial or full loss of sensation, paresis or paralysis, may be a late sign of neurovascular damage. Teach the patient to immediately report any changes of sensation or the ability to move the digits in the affected extremity. Nursing diagnoses. Impaired physical mobility, risk for infection, acute pain. Planning. The overall goals are that the patient with a fracture will 1. Have healing with no associated complications, 2. Have acceptable pain relief, and 3. Achieve maximal rehabilitation potential. Nursing implementation. Acute care. Patients with fractures may be treated in an ED or an HCP's office and released to home care. They also may need hospitalization for varying amounts of time. Specific nursing measures depend on the setting and type of treatment. Preoperative care. If surgical intervention is needed to treat a fracture, patients must be prepared. In addition to the usual preoperative nursing care, teach the patient about the type of immobilization and assistive devices that will be used. Discuss expected activity limitations after surgery. Assure them that nursing staff will help meet their personal needs until they can resume self-care. Review pain management strategies. Postoperative care. In general, nursing care after surgery involves monitoring vital signs and applying general principles of postoperative nursing care. Frequent neurovascular assessment of the affected extremity is needed to detect early and subtle changes. Carefully follow any limitations related to turning, positioning, and extremity support. Minimize pain and discomfort through proper alignment and positioning. Frequently observe dressings or casts for any signs of bleeding or drainage. Report a significant increase size of the drainage area to the HCP. If a wound drainage system is in place, regularly measure the volume of drainage and assess its character, e.g. bloody, purulent. Report increased or purulent drainage at once to the HCP. Maintain the patency of any drainage systems using aseptic technique to avoid contamination. Other nursing responsibilities depend on the type of immobilization used. A blood salvage and reinfusion system may be used to allow recovery and reinfusion of the patient's own blood. The blood is retrieved from a joint spacer cavity, and the patient receives the blood in the form of an autotransfusion. Other measures. Patients often have reduced mobility because of a fracture. Plan care to decrease risk for the many possible complications of immobility. Prevent constipation by increasing patient activity. Maintain high fluid intake, more than 2,500 milliliters per day, unless contraindicated by the patient's health status. And a diet high in bulk and roughage, fresh fruits and vegetables. These measures are not effective in continuing the patient's normal bowel elimination pattern. Give stool softeners, laxative, or suppositories. Maintain a regular time for elimination to promote bowel regularity. Renal stones can develop from bone demineralization due to reduced mobility. Hypercalcemia from demineralization causes a rise in urine pH. Stone formation from calcium precipitation. Unless contraindicated, maintain a fluid intake of 2,500 milliliters per day to decrease the risk for stone formation. Rapid deconditioning of the cardiopulmonary system can occur from prolonged bed rest, resulting in orthostatic hypotension and decreased lung capacity. Unless contraindicated, decrease these effects by having the patient sit on the side of the bed, allowing the patient's lower limbs to dangle over the bedside, and have the patient perform standing transfers. The patient is allowed to increase activity, assess for orthostatic hypotension. Assess patients for signs of VTE. Traction. When slings are used with traction, regularly inspect exposed skin areas. Pressure over a bony prominence created by wrinkled sheets or blankets may cause pressure necrosis. Persistent skin pressure may impair blood flow and cause injury to peripheral nerves and blood vessels. Assess skeletal traction or external fixation pin sites for signs of infection. Pin site care may vary. It often includes regularly cleansing with chlorhexidine, rinsing with sterile saline, and drying the area with sterile gauze. External rotation of the affected extremity is a classic assessment finding for a patient with unrepaired hip fracture. If skin traction is ordered before surgery, apply traction without trying to reposition or realign the extremity. Movement of fracture fragments can occur during repositioning, causing increased pain and possible nerve impingement. Keep the patient in the center of the bed in a supine position to provide adequate countertraction. Discuss specific patient activity with the HCP. If exercise is allowed, encourage patient participation in a simple exercise program based on activity restrictions. Have the patient perform frequent position changes, ROM exercises of unaffected joints, deep breathing exercises, and isometric exercises. These activities should be done several times each day. Teach the patient to use a trapeze bar, if permitted, to raise the body off the bed for linen changes and placement of the bedpan. Encourage and help the hospitalized patient to stay connected with friends and family by telephone or through social media resources. Ambulatory care, cast care. Most uncomplicated fractures are treated in an outpatient setting. Whatever the type of cast material, cast can interfere with circulation and nerve function if it is applied too tightly or excess edema occurs after application. Frequent neurovascular assessment of the immobilized extremity is critical. Teach the patient to recognize and properly report tightness of the cast in areas of pressure or discomfort. Explain the importance of elevating the extremity above heart level to promote venous return and applying ice to control or prevent edema during the initial phase. However, if compartment syndrome is suspected, do not elevate the extremity above the heart. Patient and caregiver teaching is important to prevent complications. Teach the patient to exercise joints above and below the cast. Tell the patient not to scratch or place anything inside the cast because this may cause skin injury and infection. For itching, direct a hair dryer on a cool setting under the cast. Confirm the patient's and caregiver's understanding of these instructions before discharge. Follow-up phone call is appropriate. Home care nursing visits may be needed, especially for the patient with a body jacket brace. Cast is typically removed in the outpatient setting. Patients often fear being cut by the oscillating blade of the cast saw. Reassure the patient that damage to the skin is unlikely. Teach the patient about possible changes in the appearance of the extremity beneath the cast, e.g. dry wrinkled skin, atrophied muscle, foul odor. Patient may be scared to use the injured extremity after cast removal. Ambulation. Know the overall goals of PT in relation to the patient's abilities, needs, and tolerance. Physical therapist is responsible for mobility training and teaching about the use of assistive aids, canes, crutches, walker. Reinforce these instructions to the patient. Patient with lower extremity fractures usually starts mobility training when able to sit in bed and dangle the feet over the side. Work with the physical therapist to give analgesia before a PT session. When the patient begins to ambulate, know the patient's weight-bearing status and the correct technique if the patient is using an assistive device. Ambulation occurs in different degrees of weight bearing. 1. Non-weight bearing, no weight on the involved extremity. 2. Touchdown/toe touch weight bearing, contact with floor for balance, but no weight borne. 3. Partial weight bearing ambulation, 25 to 50% of the patient's weight borne. 4. Weight bearing is tolerated based on patient's pain and tolerance. And 5. Full weight bearing ambulation, no limitations. Assistive devices. Devices for ambulation range from a cane, can relieve up to 40% of the weight normally borne by a lower limb to a walker or crutches may allow for complete non-weight bearing ambulation. The HCP decides which device is best, balancing the need for maximum stability and safety with the need for maneuverability in small spaces such as bathrooms. Discuss with the patient lifestyle requirements and help select a device that allows the patient to feel most secure and independent. The technique for assistive ambulation devices varies. The involved limb is usually advanced at the same time or immediately after advance of the device. The uninvolved limb is advanced last. Canes are held in the hand opposite the involved extremity. Place a transfer belt, gait belt, around the patient's waist to provide stability while teaching the patient how to use an assistive device. Discourage the patient from reaching for furniture or relying on another person for support. A patient with inadequate upper limb strength or poorly fitted crutches bears weight at the axilla rather than at the hands. This can damage the neurovascular bundle that passes across the axilla. If verbal coaching does not correct the problem, teach the patient another form of ambulation, e.g. walker, until strength is adequate. Patients who must ambulate without weight bearing need enough upper limb strength to lift their own weight at each step. Because the muscles of the shoulder girdle and upper arm may not be accustomed to this work, patients require focused training for the task. Push-ups, pull-ups, using the overhead trapeze bar, and weightlifting develop the triceps and biceps muscles. Straight leg raises and quadriceps setting exercises strengthen the quadriceps muscles. Psychosocial concerns. Short-term rehabilitative goals address the transition from dependence to independence in performing simple ADLs. They are directed at preserving or increasing strength and endurance. Long-term rehabilitative goals are aimed at preventing problems associated with musculoskeletal injury. During the rehabilitative phase, help the patient adjust to any problems caused by the injury, e.g. separation from family, financial impact of medical care, loss of income from inability to work, potential for disability. Assess patients for post-traumatic stress disorder. This is especially important if significant injury to others or fatalities are associated with the patient's injuries. The caregiver may have a key role in providing long-term care. Teach the caregiver how to help with strength and endurance exercises, mobility, and promoting activities that enhance the quality of daily living. Offer support and encouragement while actively listening to the patient and caregiver's concerns. Evaluation. The expected outcomes are that the patient with a fracture will report satisfactory pain management, show proper care of cast or immobilizer, have uncomplicated bone healing. Complications of fractures. Most fractures heal without complications. Complications of fractures may be direct or indirect. Direct complications include problems with bone infection, bone union, and avascular necrosis. Indirect complications include compartment syndrome, VTE, fat embolism syndrome, FES, breakdown of skeletal muscle, rhabdomyolysis, and hypovolemic shock. Most musculoskeletal injuries are not life-threatening. Death after a fracture is usually due to damage to underlying organs and vascular structures or complications of the fracture or immobility. Open fractures, fractures with severe blood loss, and fractures that damage vital organs, e.g. lung, heart, are medical emergencies requiring immediate attention. Infection. Open fractures and soft tissue injuries have a high rate of infection. An open fracture usually results from severe external forces. Communication of the fracture site with the outside environment can contaminate the fracture site with microorganisms or foreign bodies. Damage to the surrounding soft tissue and blood vessels impairs the ability of defense mechanisms to respond to microorganisms. Dying or contaminated tissue is an ideal medium for many common pathogens, including anaerobic bacilli such as Clostridium tetani, Measures to prevent infections and osteomyelitis are important. Open fractures require aggressive surgical debridement. The wound is initially cleaned by saline lavage in the operating room. Gross contaminants are irrigated and mechanically removed. Contused, contaminated, and devitalized tissue, muscle, subcutaneous fat, skin, and bone fragments, surgically excised debridement. The amount of soft tissue damage determines if the wound is closed at the time of surgery or if it needs repeat debridement, closed suction drainage, and or skin grafting. During surgery, the open wound may be irrigated with antibiotic solution. Antibiotic impregnated beads also may be placed in the surgical site. Patients usually receive IV antibiotics for at least 3 days. In conjunction with aggressive surgical management, antibiotics have greatly reduced the occurrence of infection. Compartment syndrome. Compartment syndrome is a condition in which swelling causes increased pressure within a limited space, muscle compartment, because the fascia surrounding the muscle has limited ability to stretch. Continued swelling can cause pressure that compromises the function of blood vessels and nerves in the compartment. Capillary perfusion is reduced below a level needed for tissue life. Compartment syndrome often involves the leg but can occur in any muscle group. There are 38 compartments in the upper and lower extremities. Two basic causes of compartment syndrome are: 1. Decreased compartment size resulting from restrictive dressings, splints, casts, excessive traction, or premature closure of fascia, and 2. Increased compartment contents due to bleeding, inflammation, edema, or IV infiltration. Edema can create enough pressure to obstruct circulation and cause venous occlusion, which further increases edema. Arterial flow is eventually compromised, causing ischemia in the extremity. As ischemia continues, muscle and nerve cells are destroyed. Fibrotic tissue eventually replaces healthy tissue. Contracture disability and loss of function can occur. Delays in diagnosis and treatment may lead to irreversible muscle and nerve ischemia. Extremity may become functionally useless or severely impaired. Compartment syndrome is usually associated with fractures, especially of long bones, extensive soft tissue damage, and crush injury. Fractures of the distal humerus and proximal tibia are the most common fractures associated with compartment syndrome. Compartment injury can also occur after knee or leg surgery. Prolonged pressure on a muscle compartment may result when someone is trapped under a heavy object or a person's limb is trapped beneath the body because of response to drugs or alcohol. Clinical manifestations. Compartment syndrome may occur initially from the body's physiologic response to the injury, or may be delayed for several days after the original insult or injury. Ischemia can occur within 4 to 8 hours after the onset of compartment syndrome. One or more of the 6 P's are specific to compartment syndrome. 1. Pain out of proportion to the injury that is not managed by opioid analgesics, and pain on passive stretch of muscle in the compartment. 2. Increasing pressure in the compartment. 3. Paresthesia, numbness and tingling. 4. Pallor, coolness, and loss of normal color of the extremity. 5. Paralysis or loss of function. And 6. Pulselessness, decreased or absent peripheral pulses. Interprofessional care. Prompt diagnosis of compartment syndrome is critical. Perform and document regular neurovascular assessment in all patients with fractures, especially those with injury of the extremities or soft tissues in the areas. Early recognition and effective treatment of compartment syndrome are essential to avoid permanent damage to muscles and nerves. Carefully assess the location, quality, and intensity of pain. Evaluate the patient's pain intensity on a scale of 0 to 10. Pain unrelieved by drugs and out of proportion to the level of injury is one of the first signs of compartment syndrome. Paresthesia is also an early sign. Notify the HCP immediately of these changes in the patient's condition. Relieving the source of pressure, e.g. cast is cut, bivalved, or dressing loosened by order of the HCP, typically decreases pain and paresthesia and can avoid compartment syndrome. Reducing traction weight may also decrease external pressures on the extremity. Pulselessness and paralysis are later signs of compartment syndrome. Do not wait until these late signs occur to contact the HCP. Amputation may be needed due to prolonged ischemia. With suspected compartment syndrome, do not elevate the extremity above the heart. Similarly, do not apply cold compresses. They may cause vasoconstriction and worsen compartment syndrome. Surgical decompression, e.g. fasciotomy, of the involved compartment may be needed. Fasciotomy site is left open for several days to allow adequate soft tissue decompression. Infection resulting from delayed wound closure is a potential problem after fasciotomy. In severe cases of compartment syndrome, amputation is done. Venous thromboembolism. Veins of the lower extremities and pelvis are at great risk for clot, thrombus formation after a fracture, especially a hip fracture. VTE may also occur after total hip or total knee replacement surgery. In patients with limited mobility, inactivity of muscles that normally help pump venous blood from the extremities to the heart worsens venous stasis. Because of the high risk for VTE in the orthopedic surgical patient, prophylactic anticoagulant drugs should be given for at least 10 to 14 days. The most common agents used include 1. Warfarin, Coumadin, 2. Low molecular weight heparin, LMWH, e.g. enoxaparin, Lovenox, Fondaparinux, 3. Aspirin, or 4. A factor XA inhibitor, e.g. Rivaroxaban, Xarelto, Apixaban. Besides wearing compression gradient stockings, anti-embolism hose, or using intermittent pneumatic compression devices, the patient should dorsiflex and plantar flex the ankle at an affected lower extremity against resistance and perform ROM exercises on the unaffected leg. For upper extremity injuries, have the patient flex and extend the wrist, if not immobilized by a cast or splint, and perform ROM exercises on the unaffected arm. Fat embolism syndrome. FES is characterized by fat globules entering the circulatory system from fractures. They collect in areas with abundant blood vessels, especially the lungs and brain. FES contributes to mortality associated with fractures. The fractures most often associated with FES are those of the long bones, ribs, tibia, and pelvis. FES can also occur after total joint replacement, spinal fusion, liposuction, crush injuries, and bone marrow transplantation. Two theories about FES exist. According to the mechanical theory, fat emboli originate from fat released from the marrow of injured bone. The fat enters systemic circulation, where it travels to other organs. As fat droplets become stuck in small blood vessels, local ischemia and inflammation occur. Biochemical theory suggests hormonal changes caused by trauma or sepsis stimulate systemic release of free fatty acids, e.g. chylomicrons, that form the fat emboli. Clinical manifestations. Early recognition of FES is crucial to prevent patient death. Most patients have symptoms within 24 to 48 hours after injury. Severe forms have occurred within hours of injury. Fat emboli in the lungs cause hemorrhagic interstitial pneumonitis with signs and symptoms of acute respiratory distress syndrome, ARDS. These include chest pain, tachypnea, cyanosis, dyspnea, apprehension, tachycardia, and hypoxemia. These symptoms are caused by poor O2 exchange. Changes in mental status due to hypoxemia are common. Petechiae on the neck, anterior chest wall, axilla, buccal membrane, and conjunctiva of the eye may help distinguish FES from other problems. It may appear due to intravascular thromboses caused by decreased oxygenation. However, petechiae occur only in about 20 to 60% of cases of FES. They may fade before they are noticed. The clinical course of FES may be rapid and acute. In a short time, skin color can change from pallor to cyanosis. Patient may become comatose. No specific laboratory tests aid in the diagnosis. However, certain abnormalities may be present. These include fat cells in the blood, urine, or sputum, a decrease of PaO2 to less than 60 milligrams of mercury, ST segment and T wave changes on ECG, decreased platelet count and hematocrit, and high erythrocyte sedimentation rate. A chest X-ray may show bilateral pulmonary infiltrates. Interprofessional care. Management of FES is supportive and related to managing symptoms. Treatment includes fluid administration to prevent hypovolemic shock, correction of acidosis, and blood transfusions. Dobutamine and nitrous oxide may be given for hemodynamic support. Use of corticosteroids to prevent or treat FES is controversial. Patient needs appropriate respiratory support. Administer O2 to treat hypoxia. Intubation or intermittent positive pressure ventilation may be an option if satisfactory PaO2 cannot be obtained with supplemental O2 alone. Some patients develop pulmonary edema and/or ARDS, leading to increased mortality. Most persons survive FES with few complications. Preventing the development of FES is important. Careful immobilization and handling of a long bone fracture are the most important factors in preventing FES. Reposition the patient as little as possible before fracture immobilization or stabilization to decrease the risk of dislodging fat droplets into the general circulation. Rhabdomyolysis. Rhabdomyolysis is a syndrome caused by the breakdown of damaged skeletal muscle. This breakdown causes the release of myoglobin into the bloodstream. Myoglobin precipitates and causes obstruction in renal tubules. This results in acute tubular necrosis and acute kidney injury, AKI. Because of possible muscle damage, assess urine output. Common signs are dark reddish-brown urine and symptoms of AKI.